عندكم دفاع جديد بتحط متخصصين.
Our talk today is about Ludwig's angina. First, we have to see the cervical fascia. The cervical fascia, layers of the cervical fascia create potential spaces that dictate the development and spread of deep neck infection. We have here the subclavian. We have here the submandibular space, which is a supra-hyoid deep neck space. It is bounded anteriorly and laterally by the mandible, superiorly by the radial mucosa, and inferiorly by the hyoid bone. Mylohyoid muscle subdivides the subclavian space into a supramylohyoid or the sublingual space and a submylohyoid space, which is the submandibular space. They are both continuous around the posterior border of the mylohyoid muscle. Deep neck infections are commonly originated by either dense abscess or odontogenic infection or oropharyngeal infection. They are generally polymicrobial, anaerobes or aerobes. The infection is life-threatening. Why? Because it might do airway compromise or it might spread to neighboring structures. That's why a high index of suspicion is important when diagnosing a deep neck infection. What is a Ludwig's angina? Ludwig's angina, by definition, is a rapidly progressive bony cellulitis of the soft tissues of the neck and floor of the mouth. It was first described by this physician, it was a German physician called Ludwig, and the word angina comes from the Latin term angina, which means to strangle. What are the causes of Ludwig's angina? 80% of patients, the cause is dental abscess, and mostly the second and third lower molar. Other less common causes are oral trauma or laceration, mandibular fracture, submandibular sialadenitis, tongue piercing, which is a fashion now in Germans nowadays. They do tongue piercing, very dangerous. Any infection can cause angina. A spread from paropharyngeal abscess or a secondary infection of oral malignancy. Most cases of Ludwig's angina are healthy patients. Nevertheless, there are some several conditions which cause immune suppression to the patient and lead and predispose the patient to Ludwig's angina, as diabetes mellitus, chemotherapy, aplastic anemia, transplant patients, systemic lupus erythematosus, AIDS, or acute glomerulonephritis. The most common organisms causing culture in these patients are Streptococcus pyogenes, Streptococcus viridans, Staphylococcus, Streptococcus, Fusobacterium, or Bacteroides. In immunocompromised patients, you might get MRSA or E. coli, Pseudomonas Haemophilus influenza, or Clostridium. What is the pathophysiology of the disease? How does it occur? The roots of the second and third mandibular molars are located inferior in the myohyoid attachment muscle. So, if any abscess or periapical abscess occurs in the second or third molar, the abscess of the pus or infection will go into the submyohyoid space. And from there, it will pass posteriorly and superiorly to the sublingual space. And as we see here, the tongue and the mouth and the floor of the mouth becomes indurated and swollen. This often begins laterally, and as it goes medially, as you see in this picture, it will push the tongue upwards and posteriorly, and thus it closes the airway. And that's why the patient will come with airway obstruction up to asphyxiation. The submyohyoid infection causes a swelling below the mandible, which is firm and woody and tender. The infection may either spread posteriorly to the parapharyngeal and rectopharyngeal spaces via the cytoglossus muscle, or inferiorly to the superior mediastinal and anterior visceral space. By history, the patient is more common a male between the age of 20 to 60. You ask about onset, course, and duration. Ask about diseases which could compromise his immunity, like diabetes mellitus, recent dental infection or dental procedures, neck or oral cavity trauma, and do a full head and neck examination, and don't forget to see his dentition. The patient clinical picture has fever, malaise, chills, weakness, dysphagia, odynophagia, tongue protrusion with drooling, trismus, open his mouth, with mouth pain, muffled voice, neck pain, and stiffness. There is swelling below the mandible, which is firm, woody, with tenderness, and as you here see, might be overlying erythema. It's either a double chin, like the first picture, or a bull neck, like the second picture. The floor of the mouth is swollen, and you might get the picture, which is the last picture, we call it a double tongue appearance. Tachypnea and shortness of breath should alarm that there is pulmonary complication. Otherwise, there is a rapidly progressive airway obstruction, which may amount to asphyxiation until you urgently secure the airway. Laboratory test, white blood corpuscles are increased, segmentation rate is raised, you do blood chemistry, there is evidence of dehydration because the patient cannot eat, cannot drink, and might have a high glucose level if he's diabetic. Culture from needle aspiration, and if the clinical presentation is severe, you might need blood culture. Imaging is very important. Do first an angle series or panoramic view to locate the dental abscess. Just radiography to detect any pneumonia or mediastinitis. CT is the gold standard. You visualize edema, you visualize loss of fat planes, pus, and you may assess the airway status. If the patient cannot be moved from the emergency department, or he cannot lie down in the supine position because he has airway obstruction, you might do an ultrasound and you see if it is distinguished between it's either phlegm or a newly established abscess which needs a surgical intervention. This is an axial CT with abscess formation in the submandibular and submental area. This is an extensive inflammatory change in the floor of the mouth with small fluid pockets. And this is a T2 weighted MRI which shows submandibular cellulitis. What are the complications of Ludwig's angina? To show you that this is a serious condition and a real emergency. The patient might have airway obstruction, epiglottitis, mediastinitis, aspiration pneumonia or empyema, osteomyelitis of the mandible, as shown in the picture, carotid artery rupture, or thrombophlebitis of the internal jugular vein, and necrotizing fasciitis. How can you manage such a case? Number one, take it serious. Get a patient with angina. Remember, it is a potentially deadly condition. You must not miss it. It must not be missed in the emergency department. It should be treated under very close observation, not at home, never at home. You have to admit a Ludwig's angina patient immediately. Thus, the main concern and priority, secure airway, and then give antibiotic, volume resuscitation, incision drainage when indicated, and after the treatment is improving and there is no acute inflammation, send him to the dentist so that he sees what the infection in the teeth is, so that he doesn't get a recurrent angina. Okay? Prior to the antibiotic therapy, IV antibiotic, the mortality rate was about 50%. Okay? The mortality rate was about 50%. Thank God now, the mortality rate is about 8%. 8% bottle is a high number. Every 10 patients you lose one. This is very serious. So, why is it decreased to 10%? Because improved imaging, the IV antibiotic, the ICU, and the advanced surgical techniques. هتعملوا ايه بقى؟ Placement of oropharyngeal airway, which is the easiest thing to do, cannot be done. Why? Because it's complicated by the tongue is elevated and you have charisma. So the airway open and immediate intubation is magnetic. And you call your anesthesiologist who can help you with it. If you can't do it and you don't have the experience, please do a phlebotomy or an awake tracheostomy. You will save his life by doing that. The best thing, and it is difficult, but by experience you can do it. It is the fiber optic laser-tracheal intubation. You put a fiber optic endoscope until he's sitting in a semi-forward position or sitting up, and you put the endoscope until you reach the cords. You tell him to take an inspiration, vocal cords open, you advance the endoscope, and then advance the tube on the endoscope and intubate the patient. It's not easy, but it's really the first, it's the easiest way to do it if you can do it. Yes? Routine oropharyngeal intubation, go to the anesthesiologist, and he can come and do it. Never, please, never do blind nasopharyngeal intubation. You can cause harm by doing this. You can cause throat, edema, laryngeal spasm, or rupture abscess when you do a blind places of intubation. Treatment thyroid instruments has to be at bedside when you try to intubate the patient. Because if you push asphyxia and start and you can't take his breath anymore, you have to do an urgent thyrotomy or an urgent awake tracheostomy, which is the standard approach in advanced stages of infection or in patients who fail intubation. IV antibiotic, we give antibiotic for gram-positive, gram-negative, aerobic and anaerobic organisms. Amoxicillin, carbonate, clindamycin, and metronidazole. If the patient is immunocompromised with gram-negative Pseudomonas, you have to give meropenem or piperacillin tazobactam. If there is MRSA bacteria, you have to give vancomycin. We modify antibiotics if you take a sample from the floor to the mouth, either by fluid sample taken, and change the antibiotic as the culture is shown. Parenteral therapy until the patient is afebrile or there is clear clinical improvement after 48 hours. We shift to oral antibiotic for 2 to 3 weeks. If there is complication, you have to increase this duration of treatment. You might use dexamethasone to improve facial psoriasis, airway edema, and to increase antibiotic penetration. Don't forget, the patient will not eat or drink for a while, so you have to give him nourishment and hydrate him, promote wound healing and fight off infection. Okay. What are the indications of surgery? Airway problem, dilates release, fail to respond to medical treatment by 48 hours, deteriorating condition as was intercepted, ascending infection, or palpable or radiographic evidence of abscess formation. What is the aim of surgical decompression? Allow the tongue, which is elevated, and push posteriorly, closing the airway, go anterior again, and reopen oropharyngeal area. In uncomplicated cases and very small cases, you might do an oral approach. This is very little or small manipulation. Mainly, attack the submandibular space abscess by doing submandibular and submental incision about 2 finger breadth inferior to the lower. Some surgeons do the incision in the skin fold from one angle to the other. And then to reach the supramylohyoid space, you have to do a vertical lung dissection in the hemostate to go through the mylohyoid muscle to reach the supramylohyoid sublingual space. يطلع غالبا سيلوس انجلس ماركو ستريك ريش فرانك فاست. And then after doing this, you do some necrotic tissue debridement and thorough irrigation and put pendulous drains bilateral and in both supramylohyoid and inframylohyoid spaces. The drains are removed when drainage is inadequate. Prevention, practice good oral hygiene, have regular dental checkups, see a dentist whenever a toothache or a foul smell is noticed in the mouth, unhealed injury or infection, unexplained pain in the mouth have to be checked, avoid tongue piercing, and follow a good nutrition diet.